Welcome, everyone, to our sports medicine podcast, 6 to 8 weeks perspectives on sports medicine with myself, Dr. Nira Pandya, Dr. Brian Feely, and Dr. Drew Lansdowne. Today, we're going to memorialize the life of Tommy John. He passed away yesterday at age 83. And I think one of the important things from an orthopedic perspective that a lot of us kind of automatically associate with the surgery is the Tommy John surgery. And for those of you who don't know, Tommy John is not necessarily relation to the procedure itself, but name of this pitcher, Tommy John, who was the first person to get this procedure done on him. Just a kind of a quick recap of Tommy John's story. He was born in Terre Haute, Indiana, signed with the Cleveland Indians at age 18. He had a 26-year Major League Baseball career, which I didn't really realize until everyone was talking about it yesterday, which is a long career for a pitcher. From 1963 to 1989, across 6 teams: the Indians, the White Sox, the Dodgers, the Angels, the A's, and the Yankees, what was known as the Indians at that time. He has a 4-time All-Star, 288 career wins, over 2,000 strikeouts, and a 3.34 ERA. He has the 3rd most wins of any pitcher not in the Hall of Fame. And I think what's remarkable, which we'll talk about in this podcast, is that in 1974, he suffered a UCL tear playing for the Dodgers. And at that point, it was considered career-ending. He was already 31. He was an established big leaguer, and he was facing the end of his career. So maybe I'll start with you, Drew. Why was a UCL tear mechanically? Why is a UCL tear kind of a bad thing for a pitcher?
Yeah, so the ulnar collateral ligament, it's the ligament on the inside, the medial side of the elbow. It connects the humerus to the ulna. And then whenever you're throwing with the hand going behind your shoulder, you're putting a valgus force on the elbow. But basically, you're stressing that ligament every time. And if the elbow is unstable, you go in that position, and then the elbow can either gap open, it can stretch. That can be painful, or it can just be that the pitcher can't control the ball, can't place the ball, or loses velocity because they can't push it as hard. So that ligament is needed because you're stressing that part of the joint every time. And then without it, you just can't effectively throw. You can do a lot of other things, but the throwing motion just becomes extremely challenging and just not possible to do at that high level.
And, Brian, question for you. So this concept of replacing a ligament, right? We do this all the time. We do it around the knee. We do it in the ankle. In the mid-70s, why was this concept of replacing ligament not present? Or were they doing ACL surgeries in the 70s? Kind of give us kind of a perspective.
So I resent the fact that you asked me as if I was around in the 70s.
I mean, you are the senior. You're our senior mentor, Brian.
Yeah. How'd you do it back then, Brian?
Yeah.
By a year over Nira. So I think if you look back to, I was trying to think, like, when did I know Tommy John's name? And I realized when I was a kid, I collected baseball cards, and I had a 1980 Flair Topps Tommy John card. And I remember thinking, wow, if you look at the back of his card, he had so many years already on it. Like, a lot of times it would list the stats, and oftentimes it'd be like 2, 3, 4 years, but his had already like 16 years on it. So I knew nothing about him as a player other than he seemed to have pitched a long time. And then when you think about, so I just had to bring up that I collected baseball cards because it seems like an obsolete thing now. But when you think about the 1970s, we would try to repair things around the knee and around the elbow, and they didn't really work. And there have been a lot of pitchers that tore their ulnar collateral ligament and then essentially went on to develop valgus instability, meaning your arm opens up, you break down the outside of your elbow, and you end up essentially with a big swollen elbow. So the classic one is Sandy Koufax, who would have pitched longer if it weren't for the fact that before many of his starts, he would have to get his elbow drained and then kind of taped up in order to pitch. Back then, what we would do is we would try to do a repair. It wouldn't really work, whether this is with the ACL or with the ulnar collateral ligament. So the idea that Frank Jobe had was take one of the ligaments in your wrist and move it because it's pretty small. You could drill little tunnels in the bones and reconstruct it. And it turns out that this actually works really well. And I'm sure we'll get into the data of how well it works, or does it really work as well as we think. But essentially what he did was he took your palmaris, which if you make a Spider-Man type of move with your wrist, there's a little bump in most people, about 80% of people, and that isn't really attached to much of anything. So it's a very superficial incision on the wrist. You harvest that tendon and you make a big incision on the inside of your elbow, expose the humerus, expose the ulna, drill little tunnels, and then kind of figure eight weave it in. I think the other thing that's kind of downplayed is how long of a recovery this was for Tommy John, because back then, he's already 31. And what they did was casted him for an extended period of time. They put him in a cast for about 6 weeks, which we never do for elbows because elbows get stiff as soon as they're in any sort of immobilization. And then took over a year off and eased him back in. And I think this might have been the original load management type surgery, because at that point he came back and ended up winning more games after his surgery than he did before.
Yeah, absolutely. And I think this, I'll kind of take a step back. I know you talked about casting, Brian. Maybe from a physiologic perspective, Drew, why, besides stiffness, is there some sort of healing that needs to be done in terms of motion? Do ligaments heal better when they're moving?
Yes, and what happens too with the joint after surgery is you get like scar tissue, adhesions, like a contracture forming, and that tissue can become tight to where you can't get the range of motion back. We'll see it in the elbow. It's probably most common in the elbow, but happens in the knee, happens in the shoulder. Like if you're not moving the joint, it'll eventually just kind of start getting stuck. And whenever you're fixing something, you want to let that heal. Sometimes motion and load across it, like it needs that to remodel. But then you're not wanting to do too much to where you're going to tear it or stretch it. But so I think, probably back then it was, not really sure what's going to happen with doing this and how the elbow's going to respond. And, let's just kind of immobilize, give it the best chance to heal and, take it from that point. But yeah, typically for the joint, motion is better. And then just balancing that with how strong the fixation is.
And then, I think when we obviously have to, anytime we talk about Tommy John, we have to talk about Dr. Jobe, who kind of pioneered this procedure. And as Brian mentioned, a lot of it was like weaving the tendon through bone. What are some of the new kind of techniques, Brian? There's the docking technique. I know you trained it, I think, wasn't it HSS where that was the docking technique was developed, or now they're using internal brace. What are some of these advances that have taken place kind of generally, Brian?
Yeah, I think the advances in surgical techniques they both changed a lot of what we do, but really they haven't really changed all that much. In principle, what we do almost all the time is we take a tendon, weave it through bone, or dock it, meaning it's a little bit shorter. Instead of doing a figure of eight, we just used slightly more advanced fixation with tiny screws to reconstruct the ligament. I think the biggest difference is with the advances of MRI and being able to see small ligaments, such as the ulnar collateral ligament, we can see exactly where it's torn, whether it's in the mid-substance or whether it's come off the bone or avulsed off the bone. And that allows us for some people to do a repair or some kind of an augmentation. And I think that's the technology that's changed the most, is figuring out the right surgery for the right person. At this point in time, there are some people that we can do a repair, but the reality is that's still a big surgery. You may not get a tendon graft, but you're still getting the inside of your arm opened up. You're getting it repaired. You're usually getting an internal brace, which is like it's like a piece of heavy nylon tape that holds your ligament in place while it heals. And the recovery is still slow. So the idea that you're all of a sudden going to quickly get back because you've had a repair versus a reconstruction, not necessarily there. I think the main difference when you look at the numbers of people who end up with not only a primary Tommy John surgery, but a secondary one, is having that repair, especially if you're like a high school or collegiate athlete that's going to keep pitching. It does open the window more likely to have a second surgery.
Yeah, and I think, kind of contrasting that, I mean, I think now more and more we're seeing this as a surgery that's done very early in someone's career, whereas for Tommy John, it was done, kind of later, well, late relatively, although he went on to pitch a lot more in his career from more of a degenerative standpoint. And I mean, it's pretty remarkable if you look at his statistics afterwards. He missed the 1975 season, recovered in 1976, won 164 more games, three more All-Star nods. So once again, it really took a tendon that was a ligament that was very degenerative and gave him kind of these, extra years on the second half of his career. Why are we seeing this more and more now, Drew, in younger athletes, right? Like Tommy John was an older athlete, it made sense, but why are 13, 14, 15, 16-year-olds getting it? And what's different about what's happening now than perhaps the degeneration that was in years past?
Yeah, I think it's a few different things. One is obviously the amount that people are throwing. That people are throwing year round, high volume, and like not taking that time off to recover. The other big thing is just the push towards velocity. So people are trying to increase their velocity because that's what gets you noticed, what gets strikeouts, what win games. And so there's this, heavy push towards throwing as hard as you can, as much as you can, for as long as you can, and then eventually the ligament wears out. And then, I mean, I think a couple other things. One is probably some attitude that, like, yeah, if I do get hurt, there's a solution and I can keep doing it and come back, which is, I think it's great, but then it also, like, the consequence isn't the same, or at least I think it's viewed that way. Like, it's a huge injury. It's a lot to recover from. Nobody wants it, but it's also like, well, if I push super hard and it eventually happens, like, I can still come back and I can still do it, and not everybody does. And then, I mean, I think before too, there were plenty of pitchers who, would probably have an injury, or players at any level have an injury, and then, like, that's just it, and they don't make it back, and you don't hear about them because there's not an option to solve it. And like, this would just be like, yeah, my arm's dead and I can't throw anymore. Guess that's the end of baseball for me. Whereas now it's, we've got methods to, treat it and recover and get back, which is amazing.
Okay, I'm going to put you on the spot, Brian. What's a more successful surgery, Tommy John surgery or ACL reconstruction?
Ooh, that's a good question. I think when we look at overall success rates, ACL is a little bit higher, but I think the relative demands on the elbow versus the knee, regardless of sport, are a little bit lower. And the reason I say that is we look at overall success rates on return to play, they're actually pretty similar. So both of them get back at about 80% for professional leagues and collegiate leagues, sometimes even a little bit higher for ACL. I think the tough part with the elbow is when you measure how much force a ulnar collateral ligament can withstand, it is less than the amount of force even a high schooler puts on their elbow every time they throw a fastball. So the fact that you need muscles and overall strength throughout your forearm and shoulder to protect the graft makes it more impressive that people can come back. But I think ACL surgery still is more successful. We also have so many more people going through ACL surgery. One of the things we don't really talk about is that if you're not a thrower, you probably don't need a Tommy John surgery, right? Yeah. So if I fall down and tear my ulnar collateral ligament, because I'm certainly not doing it throwing, I can just rehab in a brace and I'll be absolutely fine. Versus the number of ACLs we do eclipses 400,000 a year in the United States alone. So probably close to 1 million to 1.2 million worldwide. That's way more data that we get to fine tune our ACL surgeries that we just don't get, thankfully, for ulnar collateral ligament surgeries.
I think, like, that's interesting though, because with the UCL, it's only the people that are putting the most stress on it that are going to have the surgery. And even sometimes we'll see people that, like, they have some injury and it's like, yeah, well, like, I'm kind of done throwing. Like, I'm, finishing up high school and I'm not going to throw at a high level again. I can kind of throw, but it's just, if I wanted to, I'd have to have surgery. But, sure, if you're not going back to high level repetitive stress on it, then you may not have surgery or you're not going to have the injury. And then I think we'll see a lot of people with ACL injuries that they may not play competitive soccer. They may not play competitive basketball. It's more recreational things. So may not have the same kind of demands on the reconstructed ligament also.
Yeah, no, that's a very good point. But even when you look at our high level athletes, they do tend to go back. In fact, you could argue our return to sport rates are higher in ACL for the high level athletes because they have motivation to go back.
Yeah.
And, I want to go back to way back when Drew was a resident. So not quite 1974.
Huh.
But we did do a study looking at what was it really like when you returned from ulnar collateral ligament surgery in the MLB. And what we found was that, yes, a majority of people come back, but they do change their pitches a little bit. They lose about a mile an hour off their velocity, more than just age match controls. So I think one of the things that people think is that, oh, I'm going to have this Tommy John surgery. I'm going to come back and I'm going to be faster than ever before. And that's not quite true, even at the highest levels. And there are certainly people that do. So it's not like you cannot come back. But I think the reality is, as with any surgery and any recovery, you might change some of the pitching that you do, just like you might change how you cut a little bit in basketball after you've had an ACL reconstruction. And that might not be bad. So I think originally when we did the paper, I was thinking, well, that shows that you really are going to lose a little bit of velocity. You're going to change how you pitch. But that also might just be the maturation of a professional pitcher, in that you pick up a different pitch, you tinker a little bit. You've got a year plus to be off. And you may think, gosh, as I rehab, I might pick up a different pitch, or I might change my grip a little bit. And that isn't necessarily a bad thing.
Exactly. And now kind of our final question, I think this is more of a kind of a general question. I mean, I think one of the crazy things with this is, like, no one had done this procedure before. There wasn't really a procedure that was similar to this. And basically, Tommy John comes, sees Curlin Joe, or excuse me, not Curlin Joe, but Dr. Joe. Curlin Joe was his fellowship. And is basically like, I'm going to try this experimental procedure. Let's fast forward to the modern day. Can you do something like this? Just like make up a procedure and tell a patient you're going to try it? Like, what are the kind of the ethics or processes by which you can, like, do something novel? Maybe first you, Drew, and then Brian.
Yeah, I think you can. And I think if you look at how this happened, like this probably is a good model for how to do something like that. And, if you're looking at it, I mean, I think it comes back to balancing the risks and the benefits. And if he cannot throw, cannot get back to throwing, his career is over, and he wants to try something to keep going, like, we know that there's not like another better, easier path. And then, the risk would be that he goes through surgery, can't recover, and his career is still over. And I think there are some people, especially in the 70s at age 31, that he might say, I played enough, like, I'm done. Like, I don't want to go through surgery, and like, we'll just call it at that. And I think Dr. Job told him it's like a 1 in 100 chance maybe that he's able to make it back. And, but the downside would just be that he's gone through surgery, gone through recovery, maybe had a complication. But if he's informed, willing to take that, then, I think makes sense to, give it a try. And then it's the type of thing that, you don't want to just try something. Like, hopefully you have some good rationale for why this new thing might work. And then, doing it in some kind of like simulated session. So like cadaver lab or other like models where it's like, okay, yeah, this is how it's going to work. This is what it should look like. Kind of know going in what I'm expecting. And I think if you have that partnership between the surgeon, the athlete, and, they know what you're doing, why it's that thoughtful approach, then I think it's definitely possible. A lot of risk for sure. And certainly wouldn't do it on a smaller thing where, you're looking for some kind of little edge or quicker return. But I think in this setting, I think it makes sense. And I think it's interesting too, to think about what would have happened if Tommy John had said, no, thanks. Like, I am done. And, if it's the next guy who can't make it back, who doesn't win more games after, like, do we have this adoption of, or is it just like, yeah, Dr. Job tried this and he never made it back. Like, I'm not having that either. And is it just like dead at that point and like no one else is trying it? So I think pretty good on both sides to try it and have the success that they did.
I mean, the flip side is Charnley and hip replacements, right? He, in his first 100, essentially none of them were successful, and he kept trying. And I think that is probably the best comp to what happens when you try something. And this was, again, with Job, this was incredibly pioneering. Nobody had really reconstructed ligaments that much. But with a hip replacement, we were putting metal and plastic in the body, which we actually had tried since the 1880s, and it had failed spectacularly for decades and decades and decades. And it wasn't until Charnley decided to take basically 100 British people, fail, and it was somewhere around his 101st that worked. So I think, again, like Drew said, it's consent. And I don't want to say we make up surgeries all the time but we make iterations on surgeries to improve them all the time. And I think the main difference between now and the 1970s, first of all, information travels a lot faster. We're able to look across the world if we have a nuanced problem and see what else people are doing, because the techniques are shared in a much more facile manner. And we do a lot more surgery. So the ability to iterate on something that's previously been done, I think is a lot easier than it was in 1974. There were so many things that just hadn't been done yet. So I think, are we still going to find times where we invent brand new procedures? Absolutely. But I think at the level that it was happening in the 1970s, when some of these guys were pioneers in their field, probably not going to happen again, unless Drew invents something.
Keep trying.
So it will wrap up. We can obviously talk about, Tommy John and kind of how it affects, younger athletes and sports specialization, and kind of go on and on. But obviously, very sad to hear that Tommy John did pass away. Really does highlight a lot in the orthopedic community about surgeon-athlete trust, informed consent, and how medicine really has advanced through willingness to try something unproven when the alternative is career loss. So a lot of different reflections and points with his story. So thank you again, everyone, to listen to our podcast, 6 to 8 Weeks Perspectives on Sports Medicine. Check us out on Simplecast, Spotify, Amazon Podcasts, YouTube. We'll have our YouTube back up and running. And check out our clips on social media as well, too. Thank you.